you so much, Betsy. Thank you for that nice introduction, and thank you to Betsy and everyone at SUNY for having us here tonight. Happy Pride Month. As Betsy said, this is a very timely lecture for the very last day of Pride Month. So we're going to talk to you a little bit about the optometric care of transgender patients. So Lil and I, in addition to that wonderful introduction that Betsy gave, Lil and I are both pretty interested in public health topics and ethics topics. And we started this lecture about 2.5 to 3 years ago when Lil and I both started seeing an uptick in transgender patients that we were seeing down in the clinic. So we really put this together at the beginning to educate ourselves more about the transgender population. And once we gathered all of this information, we thought it would be really good to share with our colleagues and our students.
So I just want to let you know that we have no financial interest in any of the topics discussed. And it's really important that you understand that Paula and I are not attorneys. So if you have any questions regarding non-discrimination laws or provider obligations, we encourage you to seek legal counsel. We will delve into some of these topics at a very broad level, but we're not attorneys.
In addition to that, the state laws are very variable. So, what we know to be true for Michigan might not be true for New York and might not be true for any state that you travel to after you graduate if you're a student listening. So we have 3 main objectives for this course. Number 1, to have increased comfort and use correct terminology when providing care to a transgender person. Second, identify barriers to health care and common health disparities, including lack of access to culturally competent healthcare providers. And finally, to recognize the importance of a gender-inclusive practice. So as you can see, these are very, very broad course objectives, and we do have a lot of information, but because there is a lot of information and because these are very broad objectives, we're really going to keep to a very basic level and just kind of give you a broad overview, trying to stick to topics that are very, very clinical and very pertinent to you as a healthcare provider or as a practice owner. So we're going to start out with important terminology, and we're going to go through this terminology through the rest of this lecture. It is important to keep in mind that the terminology is always changing. So if you go back to dig through some information and you go through some old articles, you might find terms that are no longer appropriate or no longer used, and the terminology is just always changing. So we're going to go through this diagram here, looking at ways that an individual might define themselves. This image is taken from mayoclinic.org, and we're going to start at the top with sex and work our way counterclockwise around the diagram to go into each of those areas. So starting out with sex, another term for sex is assigned sex at birth or sex assigned at birth, and this is typically, as it says, assigned at birth when a baby is born based on chromosomes and anatomy. So traditionally, those are 2 separate bins, either male or female, but we have several individuals who don't fit neatly into either one of those bins. We might have individuals who are born with indistinct anatomy or might have extra chromosomes or missing chromosomes, and those individuals are called intersex individuals. So you'll see as we go through this diagram that it's not always a neat one or the other. It's not always a neat binary system, but if you think of each of these categories that we go through as more of a spectrum, that will help you understand the terminology a little bit better. So sex assigned at birth, if we move counterclockwise from there, we have gender identity. And gender identity is an individual's internal sense of being male, female, or somewhere along the spectrum. So the next set of terms that you should be aware of are cisgender individuals and transgender individuals. A cisgender individual is somebody whose gender identity or that internal sense of being male or female matches up with their sex assigned at birth. So a cisgender female would be somebody who identifies as a woman and was also assigned a female sex at birth. A transgender individual is somebody whose gender identity does not match up with that sex assigned at birth. So a transgender male would be somebody who was assigned a female sex at birth, but identifies as a male. So a transgender male, when we look at the transgender in front of the term, that's referring to how that individual identifies. So a transgender male identifies as a male, transgender female identifies as a female. When we have transgender individuals whose gender identity does not match up with their sex assigned at birth, we can run into gender dysphoria, which is severe psychological distress from the identity not matching up with what has been assigned to them at the hospital. In addition to having, a transgender male or a transgender female, we also have individuals who identify as non-binary. So they don't necessarily say, yes, I'm a male or yes, I'm a female, but maybe somewhere along that spectrum. So sometimes we'll hear the terms transgender and non-binary, or we may have individuals who are gender fluid, again, not fitting neatly into one of those bins, but maybe varying a little bit. Moving again counterclockwise down through those self terms, we have gender expression at the bottom, and gender expression is how one manifests oneself through social norms of masculine, feminine, or something else. So feminine individuals, tend to be the more classic, traditional female expression, masculine, traditional, more masculine expression. And again, it is a spectrum. So we have individuals who might fall anywhere along that spectrum, or individuals who fall right in the middle and don't necessarily fit neatly into one of those bins. Moving along to the last category is sexual orientation. And sexual orientation, it's important to know it's a very, very separate thing from gender identity. It's a totally separate concept. Sexual orientation is the gender that a person is attracted to. And again, we see a wide spectrum of individuals there. It is important to keep in mind, though, that it is not related to gender identity. However, when we think about the transgender population is typically lumped into the LGBTQ population. So sometimes you'll hear the term sexually and gender diverse. So as you're reading through papers, as you're trying to look up your own information, you might see terms like transgender and non-binary, or TGNB, which is specific to transgender individuals. Or you might see terms like sexually and gender diverse, which would include the whole LGBTQ population. Moving along from there, there's a lot of confusion with the terminology because there is a very large lack of understanding about what gender identity is. So many people think that a transgender individual can, just kind of picks what they want, or they can fluctuate back and forth between what gender they want to identify with that day. And that's really not the case at all. We have several different biological studies that have looked at the brains and the physiology of transgender individuals. So I'm going to start with the brain anatomy. And if you look at this first diagram, we have these kind of blue brains on the top and the orange brains on the bottom. So we know from typical gender studies that male brains and female brains are a little bit different in both their anatomy and how they respond to things physiologically. When they've studied transgender brains, they have found that transgender individuals, their brains tend to look more like the gender that they identify with. We also have some studies from fetus studies, or studies from pregnant women looking at that brain development. So what we tend to find in transgender individuals is that when the baby is in utero, there is either insufficient estrogen production from the mother, or there is poor receptor sensitivity, again, to estrogen, which can sometimes match up with an individual being transgender. So we have several different biological factors. Gender identity it's a very innate internal sense of being male or female, or again, somewhere along the spectrum. So it's not something that an individual can just choose or change their mind about day to day. Most children have created their gender identity by about 6 years old, and we have some studies that suggest that children have a gender identity as early as 3 years old. So you will see transgender individuals all the way from your pediatric patients all the way through your geriatric patients. So I'm going to talk a little bit about a case that I saw, and this was one of the first transgender patients that I saw down in clinic. And she came to us, she was a 31-year-old transgender female. So she was assigned a male sex at birth, but identifies as female. She came in with chief complaints of diplopia and headaches, and she was oriented, she knew where she was. She knew that she was at the eye clinic. She knew the day and the week and all of that, but she had very, very slow responses and seemed very nervous and very anxious and very thoughtful about everything as we were talking to her throughout the exam. For her medical history, she had seasonal allergies, anxiety, depression, and gender identity disorder, which is a term that you'll sometimes see used in place of gender dysphoria. For her medications, you can see she was on a pretty significant amount of medications for a 31-year-old: anti-allergy meds, estrogen, acne meds, antidepressants, and anti-nausea medications. She was also a heroin user. She did note that she was currently in withdrawal, not because she was in any formal rehab program, she just hadn't had a fix in a while. Pertinent clinical findings: she did have sluggish dilated pupils. She had mildly reduced acuity, about 20/25, 20/30 or so. pretty reduced accommodative invergence findings, and then this kind of moderate dry eye appearance. She had some scurf, she had some mild injection of her conjunctiva. We did see her back for 2 follow-up visits. We got her some reading glasses, and she came back the first time. Things weren't a whole lot better. And when she came back for the second follow-up visit, she told us that she had the intent of committing suicide. So at that time, we did have to stop the exam and get her the appropriate medical care. And then we have lost her to follow-up since then, unfortunately. So this was a patient for me that was a really big red flag that, you know, I wish I could do more for my transgender patients. I wish I had a better understanding of my transgender patients. So with that, let's get into some of these statistics, which in many ways are similar to this first patient that I just talked about. So one of the biggest surveys that we have of the transgender population is the US Transgender Survey, or the USTS, that was done in 2015. They have plans of updating that survey in 2020, but like everything else, that was put on hold because of COVID. So 2015 USTS is still one of the biggest studies they have. And we looked at 27,000 adults across the United States, and you can see the distribution of those respondents in that map there. From that study, we found that our transgender individuals make up 0.39 to 2.9% of the general population and approximately 3.5% of the LGBTQ population. We are seeing those numbers increase a little bit as more people are becoming more comfortable with identifying as transgender. The statistics reported in that study, though, were a little bit alarming when we look at some of these pretty significant barriers to healthcare and physical abuse. So if you go through the numbers here, you can see a high percentage of physical abuse by others, including being physically attacked in school or leaving school because of the physical abuse they were experiencing. High barriers to healthcare, including 13% who reported that healthcare professionals tried to stop them from being transgender. Very high amounts of poverty and unemployment. You can see 29% living in poverty compared to 12% of the general population. High amounts of substance use and abuse, and high amounts of behavioral health issues. And I'm going to get into the behavioral health issues on the next slide here, specifically looking at serious psychological distress, suicide attempt within a lifetime, and also within the past year. So if you look at the orange bars here, the orange bars are the transgender population, and the blue bars are the general population. So for the first number, serious psychological distress, we're seeing 39% of our transgender individuals compared to only 5% of the general population. Suicide attempt in a lifetime, 40% of the transgender population compared to just 4.6% of the general population. And then finally, suicide attempt within the past year, 7% of the transgender population compared to 0.6% of the general population. When those numbers are broken down by racial minorities, those discrepancies are even higher for the racial minority groups. So really alarming, very concerning statistics here, but it is important that you know that having psychological distress, attempting suicide is not inherent in being transgender. It's because of the barriers to healthcare and the physical abuse that we see some of these behavioral health issues. The good news is that we do have some statistics that show how we can decrease some of these discrepancies. So the Trevor Project is another group that looks at transgender care, and Trevor Project is specifically for transgender youth. And they ran a survey in 2019 looking at almost 26,000 LGBTQ youth between the ages of 13 and 24 years old. So if you think about this survey compared to the USTS survey, which was 18 and up, you can see that there might be a little bit of overlap in some of those numbers. Again, this is the youth is a growing population of LGBTQ individuals as more people are becoming more comfortable with identifying as transgender. So when we look at these numbers, the survey that the Trevor Project did showed that if we have family acceptance, if we have use of the individual's chosen name, if we have appropriate social transition, and if we have appropriate medical care, we see the behavioral health problems, the suicidal ideation decrease significantly. So in accepting family, you can see suicide rate decreases from 57% down to 31% in highly accepting families. Use of chosen name, 29% decrease in suicidal ideation and 56% decrease in suicidal behavior. Children who have transitioned and who have gone through a social transition demonstrate comparable levels of self-worth and depression as non-TGNB children. And then finally, appropriate medical care, behavioral problems reduced from 44% down to 22%, and significant emotional distress decreased from 30% down to 11% with the appropriate medical care and family acceptance. So because acceptance, part of acceptance is understanding, we're going to go into a little bit more detail about what gender transition is. So there are four main areas of gender transition, and gender transition is defined as the process of aligning identity with the outward appearance. So you can have cosmetic or social transition, hormonal transition, which we're going to spend a lot of time talking about in a few slides here, surgical transition, and legal transition. And we're going to talk about each one of these topics, but we're going to start out with cosmetic and social transition. So before I get into that, though, I want to note that transition is very, very different for every single individual. So it is an individualized approach. You don't necessarily have to have a surgical transition to be considered transgender. Some transgender individuals will go through one of these changes or all of these changes, or maybe only two or three of these changes. So again, it's very, very individualized. It's going to be completely different for every single person. I have these pictures up here of Laverne Cox and Elliot Page because they are celebrities who you may know of as being transgender. Laverne Cox obviously has been out for a little while. More recently, Elliot Page. I have their pictures up here to point out that if either one of these individuals were to come into your exam and sit in your exam chair and you were to give them an exam, you wouldn't necessarily know that they were transgender without having that background information. So it's very important that you don't make assumptions about an individual, whether you know they're transition or whether you know that they're transgender or not. And Dr. Lil will talk about how to address these patients a little bit later in the presentation and how to go through that intake process. So let's start out talking about cosmetic and social transition. Cosmetic transition, it will typically take place through hair and makeup, and I think it's pretty easy to think about how you can change your hair, change your makeup to look more masculine or more feminine. Same thing is true with clothing, same thing is true with accessories, which might be jewelry, it might be glasses, it might be ties or whatever. But what's very important when we think about social transition is pronoun use. So when we typically think about pronouns, we think about he, him pronouns, and then she, her pronouns. And that is, again, that very binary system where we've got males and females. I have this list here of several different pronouns that are out there, and this is an abbreviated list. There are actually way more pronouns than what is on this list here. But one that's becoming more and more common is the pronoun they and them. In 2019, the Merriam-Webster Dictionary actually added themselves as a gender-neutral reflexive singular pronoun used in place of himself or herself. So this is one that's a little bit tough to get used to because typically you think of them as being plural, but we can assure you that as of 2019, Merriam-Webster has said, yep, this is definitely a singular pronoun if an individual is non-binary or they don't identify strictly as male or female. I do have kind of a pronoun guide down at the bottom there in that black box, so you can kind of look through and use some of these pronouns in place of those empty spots, and hopefully that will help you understand those pronouns a little bit better. We do have a lot of information to get through, so we can talk more about this in the Q&A if you have questions. What I do want to point out, though, is dead naming, and dead naming is a very offensive practice, and it's something that you want to try to avoid at all costs. So many transgender individuals will change their names to a name that matches up with their gender identity. So let's say you have a patient that comes into your office who goes by Elizabeth, but they were assigned the name at birth of Richard. If you were to call that individual Richard, you would be dead naming that patient. And that patient really doesn't want to have anything to do with Richard. That individual doesn't identify as Richard. That patient doesn't identify as being a male like Richard was assigned. So it's very inappropriate to use an individual's name if they no longer associate with that name. And that's pretty easy to do. I mean, we use people's names that they want to be called, nicknames, all the time, right? And if we think about somebody that walks in your practice that's named Elizabeth, you might ask if they go by Liz or Lizzie or Beth or whatever the case may be. So just make sure that you go by the patient's name that they want to be called or that they are called currently. And again, Lil will talk about kind of that intake process a little bit later in the presentation. So the next area of transition is surgical transition or gender confirmation surgery. And typically when we talk about gender confirmation surgery, we talk about top surgery or bottom surgery. And you can see based on the line that I have in that picture, which those are referring to. A lot of times, even in the literature, we don't see it in a lot more detail other than top surgery or bottom surgery. However, there are other options that are available. There might be facial cosmetic surgery, tracheal cartilage surgery if an individual wants that Adam's apple to be more prominent or less prominent. We might see body contour surgeries, body hair surgeries, vocal surgeries, and I have silicone injections down at the bottom in italics because we do sometimes see surgeries or have read about surgeries that are really more like off-label treatments. However, if you think back to the statistics that I gave you about discrimination from healthcare providers, there are many transgender individuals who don't feel comfortable going to see a medical doctor, so they find these underground treatments that are sometimes a little bit more risky. So we do see these off-label treatments in addition to the top surgery and the bottom surgery. Generally speaking, the top surgery does tend to be a little bit more common. If you think about breast augmentation, that's something that we see all the time and that surgeons are very comfortable doing to enhance or reduce that tissue. So top surgery is a little bit more common than the bottom surgery. I am going to switch it over to Dr. Cal to talk a little bit more about gender confirmation care.
Thanks, Paula. So moving a little bit beyond kind of those social and more cosmetic transition, and we're really not going to talk much more about surgical corrections or surgical treatments because, you know, they're pretty self-explanatory, I think, or far beyond the scope of our expertise. But I do want to talk to you more about the psychological, hormonal, and some of the more, you know, other types of treatment for gender confirmation care. Our medical experts in this area do consider additional treatments to be medically necessary treatment for our transgender patients. As Paula had pointed out in one of the earlier slides, you know, some of these treatments can really can create some significant reduction and improvement in the behavioral health comorbidities that these patients might deal with. So it's really important that we know what the appropriate treatment is for these patients. So along with many other things, when Paula and I started researching this topic, we really didn't know how many patients really had gender confirmation care. So we did a bunch of research in this area, and we found out that about 80% of the transgender population does use at least hormone therapy, or what is called gender affirming hormone therapy, or GAHT to abbreviate. So a significant number of transgender individuals will have hormone therapy at some point in their transition. Now, what is interesting about this is that sometimes patients start and stop, or they start, you know, they might take it for years and then stop. So again, like Paula had already mentioned, the path to transition is very different for every individual. Looking at gender confirmation surgery, just to allow you to put kind of some percentages to these procedures that we're talking about, overall, about 25 to 35% of transgender patients do receive some type of surgical treatment. And you can see for our trans men, that number is higher, 42 to 54%, where in our trans women, that's going to be a lower percentage, about 28%. And interestingly, even some of our non-binary patients do have some types of surgical confirmation. So about 9% of those as well, which I found interesting. Sorry, Paula, you're going to forward. Paula's running the slide, sorry.
Oh, there we go.
There we go, okay.
All right, so very briefly, I'm going to talk about kind of general hormone therapy, and then Lil's going to get more into specific ocular side effects. So when we look at the different types of hormone therapies, we have feminizing hormones, masculinizing hormones, and hormone blockers. Our feminizing hormones are typically estrogen and anti-androgens. Our masculinizing hormone is testosterone. So if you look at this table here, we have several intended systemic side effects, or the side effects that the individual wants to get from these hormones. Typically, that's going to be increasing those secondary sex characteristics. However, there are also several unintended systemic side effects that may go along with that hormone treatment. So the top three for each one of these categories: for the feminizing hormones, venous thrombosis, weight gain, hypertriglyceridemia, and then for testosterone, polycythemia, weight gain, and sleep apnea, those are the ones that we tend to see most commonly as unintended systemic side effects. However, I have a couple others in bold there. You can see type 2 diabetes, hypertension. Those are some that are certainly pertinent to us as eye care providers, as things that we might want to be aware of as a secondary side effect of these medications. What's interesting about these meds is that they can take up to 2 years to have the full effect, but typically we'll start seeing changes as early as 2 months. Now, again, these are going to be very individual to each patient. So there's going to be different dosages that are out there, and there's going to be different routes of administration. Those might be oral meds, that might be a patch, that might be an injection. But because we are working with hormones, these individuals should have an endocrinologist that they are working with. We do have a last category of medications, which is hormone blockers, and I'm going to switch it back over to Lil to talk about hormone blockers and again go into some of the ocular side effects that we see with this hormone treatment.
Now Paula gets to take a break for a while, so I'm gonna talk for a bit. All right, so I want to just elaborate a bit more on hormone blockers because probably most of us are least familiar with this in the classes of medication. So these are technically called gonadotropin releasing hormone analogs. And these, as Paula had already mentioned in the previous slide, are used primarily to delay or stop the development of our secondary sex characteristics, primarily in our gender questioning youth. So, this might be for that younger child or adolescent who is questioning their gender. This is a way for their healthcare providers and their caregivers to kind of just put the conversation on hold. Let's just start hormone blockers and kind of just, we're just going to ride this out for a couple of years to see, where we're at as we're approaching puberty. And that's essentially what these drugs are for. Clinical practice guidelines do recommend the initiation of hormone blockers prior to the age of 16, which makes perfect sense, right? If we're trying to slow the progression of secondary sex characteristics, we want to get them started, in today's day and age, probably as soon as we can, certainly well before the age of 16. Boys can start as young as 12 to 14 years, and girls can be started as young as 10 to 12 years. Now, I will tell you, every time Paula and I give this lecture, we get great feedback from the crowd. And we've heard from previous listeners that their children have been started on these as young as 8. So we also have learned that there's really a great deal of regional difference between when hormone blockers are started in different parts of the country. So I think perhaps in more, let's say, progressive, liberal, I'm afraid to use an incorrect term. So let's just say in some parts of the country, these might be started at younger ages than in other parts of the country. So don't be surprised if you hear discrepancies in when the hormone blockers are started. There are really two main drugs in this class. We have Leuprolide, which is an injection, and this injection lasts for about 1 to 3 months. This one is interesting because it does have some ocular side effects of blurred vision, and the blurred vision typically starts right away within 1 to 2 hours of getting this injection, and it can last up to about 2 weeks. There has been some suggestion in the literature that this is caused by a myopic shift due to choroidal effusion, so very similar to what we see in Topamax. But the number of cases has been very, very small. There's not enough evidence really to state that conclusively. And it has maybe been linked also to some rare cases of IIH in young patients taking this medication as well. The second type of medication is going to be our Hysterlin. This is an implant, and this one does last for 12 to 24 months. It does seem to have maybe a little higher safety profile, and there are known ocular side effects with this medication that I could find. Great. So let me talk to you a little bit about the ocular effects of hormone therapy. So Paula and I hear over and over again, are there physiological or pathologies that occur in our transgender patient that we should be aware of when it comes to an eye exam? And really, outside of those systemic unintended consequences that Paula has already reviewed for you, there are actually just a few ocular side effects from these medications, and most of this you know already. So this is coming from the DEUCE-2 study, which has been out for a number of years now, and probably everyone here is very familiar with it. But essentially, we need to remember that testosterone is an androgen. And the DEUCE-2 study did tell us that there are androgen receptors in some of our ocular tissues, most importantly, the lacrimal gland and our meibomian glands. And that we did learn that androgens stimulate function in those ocular surfaces. Therefore, exogenous testosterone may certainly improve the signs and symptoms of ocular surface disease and dry eye. Estrogen is going to be exactly the opposite. We don't know as much about estrogen in the eye, but we do know that there is estrogen in the tears, and there is messenger RNA for estrogen receptors found again on those meibomian glands and lacrimal glands. So these findings do suggest that our eyes, the estrogen is synthesized and metabolized in the eye, but the exact pathway or purpose hasn't been identified. And I did look that up because it has been a bit since DEUCE-2 came out, and we still don't really know much beyond that, at least what my research indicated. So evidence which should suggest that estrogens are going to decrease our meibomian and lacrimal secretions, and that they're probably going to worsen the signs and symptoms of ocular surface disease and dry eye. So that's really, think about our ocular surface stuff, and that's one of the main things that you would want to pay attention to. Now, this topic is interesting. So we're talking about this link between testosterone and IIH, and I think probably, if you've been paying attention to this issue of transgender patients, You probably have already heard of this one. So what's interesting is that there are some really current and deep research going on right now into the exact mechanism of intracranial idiopathic hypertension. And one of the more recent studies published in the UK suggests that there's a 108% increase in the prevalence of IIH between the years of 2002 and 2016. So globally, we're seeing IIH more, and I don't know about you guys, but that certainly does align with what I'm seeing in clinic. I've seen more IIH in the last 10 years than I did, in my previous time in practice before that. And this increase does appear to mirror the global obesity rate, which makes sense. If we know that that is an underlying cause for this ocular condition, then, as those obesity rates increase, it makes sense that we're seeing this more often. But interestingly, there are 10 plus published cases of trans males, so a female to male transition, developing IIH while undergoing GAHT with exogenous testosterone. So, there haven't been anything newer than probably the last 2 or 3 years, because you know how that goes. Once we know about it, they quit publishing cases, but there's at least 10 in the literature. Very interestingly, a couple of the cases that they were treated without their treating physician ever even knowing that they were transgender, which is unbelievable, but true. The specific mechanism or cause of IIH has not been proven for non-testosterone related or testosterone related cases. So, but like I've already mentioned, this is a really active area of research right now because we're seeing the incidence increase. We need to have a better understanding of what causes it and how to treat it. Fortunately, the treatment of IIH in our transgender people is just like it is for a traditional patient. We're going to counsel weight loss. They might perhaps need some oral CAIs, but most patients do very, very well. And in fact, hardly ever do they actually have to stop the hormone treatment during therapy. Sometimes the dosage needs to be reduced, but most of the time the IIH can be treated in conjunction with them continuing their hormone therapy. All right, so we can't move on without just reminding you of some of the ocular effects of antidepressants and anti-anxiety medications, because so many transgender individuals, just so many people in general, everywhere right now, are on these medications. So certainly most of these should be familiar to you, with our pupil mydriasis, our accommodative paresis, and dry eye being probably the most common side effects that we're going to see. Uncoordinated eye movements as well. Paula would tell you she's a PEDS BB person, so she probably looks at that a little more carefully than I do. And then these other ones are going to be much less common down towards the bottom. But certainly those large pupils with accommodative issues are something that you're going to want to pay attention to in patients taking these medications. All right, so I know that this picture is probably shocking for some of you, but I do want to remind you about prescribing oral medications in particular to a transgender individual who might still retain the ability to have children naturally. So, in some of the pre-questions I see, why do we even need to know about this, or when would we need to ask? I do think it's important to know exactly kind of what gender and the potential for childbearing before you write a prescription for an oral medication. So just something to kind of keep in the back of your mind when you're writing those oral prescriptions.
So just kind of wrapping up the medical care here and the clinical care, important to keep in mind that when we're looking at sex and health differences, we have some of these conditions that we think of as being traditionally female conditions. And I think IIH is a really great example of that. I mean, we all have that clinical profile of what we think of as a patient who has IIH, is going to be female, is going to be overweight. And then we also have some more traditionally male conditions as well. When we're working with transgender individuals, those individuals may not fit that typical sex profile that you're used to. So if you're seeing some of these things that maybe don't match up from what you've learned about your traditional sex differences, you might need to dig a little bit more into the medical history and ask a little bit more about hormone treatments. We all know that patients don't necessarily tell us about medications if they don't think that they're pertinent to the eye. So if you're seeing some of these things, you may need to ask about if they are on any type of hormone treatment. Certainly, you're not just going to want to say, hey, are you transgender? But again, Lil will talk about the intake process and getting the appropriate intake on that in a couple slides here. The other thing you should know is that you may have lab test discrepancies. If you send a patient out for lab work, for blood work, what they have found in looking at transgender individuals is that the transgender individuals really don't fit neatly into our typical female or typical male categories, and their normal lab numbers look a little bit different than the normal or the kind of traditional female numbers and traditional male numbers. So again, if you are sending a patient out for lab work, important that you note that they are transgender or that they are taking hormone therapy so that the lab can analyze those numbers appropriately.
Okay, so we're going to move on to kind of the next phase, and this is the legal transition. So we're going to talk about 3 specific areas: our legal name changes, a sex indicator change, and also changes in our personal documents. So I'm going to start with the easiest one first, and that is our legal name change. Anyone can change their name for any reason. Doesn't have to mean that they're transgender, right? If you're Prince, you can change it to a symbol. It doesn't even need to be a name. So any one of us can change our name at any point. Super easy. File a fee, file the paperwork, and it's done. Okay. So I want to kind of elaborate more on changing our sex indicator. And by that, I mean the traditional M for male, F for female, and our document changes. They kind of go hand in hand, because when we talk about a document change, most of the time what we're talking about is, can the sex indicator on a document be changed? Okay, so that's what we're really talking about here. So the other thing we need to keep in mind is that most of our documents come from different issuers, right? So a passport's going to be a federal document, driver's license going to be a state, birth certificate, state, county, or city, however it works in your location. So each one of those will have slightly different rules and regulations, which creates not only confusion for transgender people that are trying to make these changes, but also typically results in a situation where maybe their documents don't match. So some of them they've been able to change, but some of them they can't. So I would say the easiest one to have altered is going to be the driver's license. There are a number of states that are starting to allow not necessarily a change from M to F, but certainly a change from either of our traditional binary indicators to kind of a gender neutral, which most states are kind of moving to X, seems to be the new trend. So some states have been allowing a gender neutral indicator on a driver's license for quite a long time, and more states are kind of coming online with this process all the time. This graphic I put together a couple of years ago, I'm sure it's outdated now, but some states, where we have a car, you're allowed to change your sex indicator on your driver's license and choose a gender neutral option with no explanation, really. You don't have to, show that you've transitioned or do anything, you just change it, okay? The hardest one to change is going to be the birth certificate. So I have some states with the babies. I just realized I made all the babies blue. I wasn't trying to imply anything with that. I don't know why all the babies are blue, but I didn't mean anything by that. So, some states do suggest that transgender individuals are able to change their sex indicator on their birth certificate. What I'm going to tell you from talking to people and doing research is I think that is something that is incredibly difficult to actually do in real life. I had one person who was corresponding with me describing that actually is almost like an urban legend. Like, yeah, they say we can do it, but we really can't. Some states, to make any kind of indicator change on the birth certificate, really have to go, all the way to full surgical treatments. So it's not an easy process. And because of that, I don't think many transgender people are really pursuing that right now, but it's just something to be aware of. So you very well might have a patient who comes in who has a driver's license that has a sex indicator of X and an insurance card that has either an M or F. Don't be surprised by that. And you would bill it with whatever is on their insurance card. That just means that they were able to get their driver's license changed. All right, so let's talk about some legal considerations for providers. I'm going to touch briefly on some federal and state laws, and then we're going to talk some about medical records compliance, and then some just some patient privacy things to keep in the back of your mind. So first of all, I want to point out my source for this information. And there was a great publication that was put out last summer by the National Academies of Science, Engineering, and Medicine. I've included the source both here and in our references at the end of the presentation. If you would like to learn more about the transgender population, this is an excellent, excellent resource too. It is free, so you can download it for free. So most of you, I'm going to assume, know that there was a very significant Supreme Court ruling in June of 2020, just last year, and that was the Bostock versus Clayton County case. And in that case, the Supreme Court essentially ruled that workplace discrimination based on either sexual orientation or gender identity does in fact constitute a form of sex discrimination. So the question that was really at the basis of this case was whether Title VII of the 1964 Civil Rights Act, which many of you I'm sure know, prohibits discrimination in the workplace based on sex, so based on male or female, whether that statute also prohibited workplace discrimination based on sexual orientation or gender identity. So that was the issue at hand. And in fact, the Supreme Court did say, yes, it does in fact protect workplace discrimination against sexual orientation or gender identity. So this was a huge, huge win for our transgender friends. The ruling is even more significant than we might have expected at first glance. So essentially, this ruling applies to all federal statutes that prohibit sex discrimination in education, which would be our Title IX, in housing, which is our Title VIII, in credit, and in access to healthcare and health insurance coverage through the Affordable Care Act. So essentially, any law that had a federal non-discrimination statute was affected by the Bostock versus Clayton County ruling. Unfortunately, we still have our transgender friends still continue to face legal difficulties basically everywhere else, including in criminal law, family law, policies regarding identity documents, which I just was explaining to you, certainly our rules pertaining to military service. Essentially, anything that is not protected by an anti-discrimination law is still kind of fair game. And cities and states do have some laws that help fill in those legal gaps, but less than half of states have any non-discrimination law that protects transgender people. And in fact, some states actually have negative laws, so things that specifically target transgender people. And we looked this up. GLAAD states that at least 133 anti-LGBTQ state laws have been introduced just this year. This was 2020, not 2021, including 111 bills that target transgender people. And that includes 69, you guys can read this, but there's a significant push to introduce these anti-transgender bills in many of our states. And you can see my source here if you'd like to learn more about that. So how do you keep up? You know, Paula and I feel like we're constantly sending each other articles. We kind of grab snippets out of the headlines. I mean, at least a couple of times a week. And I just sent her one yesterday. So it's really difficult to keep up on what's going on in your locality. So this is a wonderful resource. This is from the lgbtqmap.org. I happen to just grab the equality map, but you could really go to this website and find any information dealing with gender identity, policy, anti-discrimination. It's all down, it's all here. It really even down to the city level. Like I could click on Michigan and drill down and find out exactly what protections are in place in the city of Grand Rapids or in the city of Ann Arbor. So it's a wonderful resource if you would like to know what's going on. They're updating it constantly. And what I like is that they kind of rate the states. So these colors have changed on the most current map, but essentially green means that there is a high gender identity policy tally. So that's a state that actually has good protections for transgender individuals. And then we're going down to our dark brown, brick orange, whatever color you want to call that. Those are actually going to be states that have negative gender identity policies in place. So not only are we not protecting, but we're intentionally trying to discriminate against transgender individuals. So it's a really interesting source. I encourage you to take a look here if you would like more information about your locality.
All right, so this is another case that we want to talk about briefly. This was a young man, 14-year-old transgender male. And for this young man, mom called me before the exam and said, you know, he is a transgender male, but he has severe gender dysphoria. You know, I know you work with students, so please make sure that you don't bring it up in the exam. Please make sure that your students don't bring up in the exam anything relating to the fact that it says that he is a female on all of his legal paperwork. Please don't bring up the official legal name. It's very upsetting if that happens. So 14-year-old transgender male came into the office, went through the exam, really nothing all that exciting. You can see his exam data here, some depression and anxiety, seasonal allergies. He was taking one of those hormone blockers that Lil talked about earlier. As far as social history, he was bullied at school, but you can see the following year, he actually switched to an all online school prior to the pandemic. So he was really ready for last year, and he's been doing great since then. I've been seeing him for several years since then. So at this time, I mean, the exam itself wasn't all that exciting, but it brought up a lot of questions for us about, okay, well, we know that he's a transgender male. We know that he has this name that he goes by now, but how do we make sure that we get the appropriate information in the chart, that we can still respect the patient, respect his pronouns, but also make sure that we have the appropriate legal paperwork through, that he is able to bill the insurance for his exam, and also make sure that we have accurate information in the chart. So Lil's going to talk a little bit more about all of those medical record keeping type issues.
Okay, so I'm going to assume that all of us here, most of us on this call, are practitioners, and that we've all had, training in medical record keeping and how to keep an appropriate medical record. So we all know that, underlying good record keeping is this idea that it should be accurate, it should be timely, and it should reflect what really happened in our exam, right? So what happens though, and I can't believe how many of you asked this on the questions, or I can believe it. This is probably one of the #1 questions that we get. What happens when the patient identifiers do not match their legal documents, right? And then what should you do when the patient's preferred name and pronoun don't match legal name and sex at birth? Okay, so this is actually pretty easy, you guys, and I'm happy to tell you that. So like Paula had already said, when we think about the name, okay, just think about their preferred name or their selected name or whatever you want to call it. It's no different than what we've always called a nickname or an alias, right? So every EHR, even way back in paper documents, we had legal name and then nickname or alias right after it, where you could write in what the patient really wanted to be called. You can do exactly that with your transgender patients. It's very, very simple. When it comes to our sex assigned at birth or our sex indicator on our demographic screen, right? And then gender, those are two separate things. You can have two totally separate fields. So for those of you that are using EHRs, I want to reassure you that they do have a place somewhere that you can record gender identity. It is a field that sometimes needs to be turned on in the background in your settings. So if you're not someone that's super familiar with how to change the settings in your EHR, talk to your software manufacturer, because way back when, if there's probably like 10 of you on the call that are old enough to remember meaningful use, but way back when we had to have our EHR certified for meaningful use in the late 2000s, even then, EHRs that were certified for meaningful use had to have an ability to record gender data. So it's there, it's been there for a long, long time, you just might not see it. So in your EHR somewhere, you will have a gender field. You will already have a sex identifier field. All you have to do is record their sex assigned at birth, which is probably what is still on their legal documents and on their insurance card, in the male/female box. But then you'll have to ask them about their gender. And I will show you some examples about how we're doing that here at MCO. And then you simply record that in a different field. Now, the tricky thing is that you need to remember to look at it in your EHR. One of the worst things that you can do is continue to use an inappropriate name or an inappropriate gender once you've already had this conversation with your patient and recorded it in the record. So what we've done on our system is that we've highlighted on the demographics field that gender field so that it's bright yellow. We remember to look at it. And then it's just part of practice to remember to look at preferred name, nickname field, whatever you want to call it. So you just have to change your processes a little bit. And I'll go through again how we ask these questions at intake. I do want to just put in kind of just a little word of caution about privacy. You really do not even have to address the fact that the patient is transgender beyond collecting their gender information. If it is not pertinent to the eye exam, you don't have to have a conversation about it. And in my head, it's no different than sexual orientation. I don't have a conversation with every patient about what their sexual orientation is, just like I don't have a conversation about every patient who might be transgender. If it's applicable to the eye exam, ask questions. If it's not, you don't need to know. It's just that simple. And if you do have someone that you know is transgender, then protect that information. Don't talk about it in the office. It's not something to be discussed in the break room. You treat them with the same level of maybe even a heightened level of privacy than you would with just a typical patient. some of you might be thinking, I'm just going to ignore this because this is complicated and it's never going to happen in my practice and I'm just going to ignore it. It is important. It's important that we have good information on our transgender patients for epidemiology, for medical decision-making, and for patient-centered practice. You know, Paula had mentioned earlier on that the percentage of transgender individuals in the United States is anywhere between 0.39 and 2.9%. Well, the reason that we don't have a better number is because we don't collect the data. So until we collect data consistently on this population, we're not going to have good information. So we all have to do our part. Put on my public health hat for a second. Okay, here's the why. So Paula had mentioned a few of the health disparities in one of her slides earlier, but one thing that I think is just vitally important for us to understand is that we as healthcare providers are creating part of the problem. And we're creating the problem because 33% of transgender people who had seen a healthcare provider in the previous year had at least one negative experience, and 27% of transgender people reported having been denied healthcare outright. So what we're starting to see as we're learning more about the transgender population, and this previous resource that I pointed out from NASEM really delves into this, that many transgender people avoid going to the doctor, any doctor, because they assume that they're going to be discriminated against because it has happened so commonly in the past. So we have to do better. Otherwise, we're going to continue to see these health disparities increase. Okay, so creating a gender inclusive practice, where do you start? So first of all, we need to increase awareness among our providers and staff, what we're doing here. We need to obtain and provide training to everyone in the practice. And we practice what we preach. The very first people that we gave this training to about 1.5 years or 2 years ago was to our staff, to our front desk staff. We need to update the processes such as patient registration, EHR modifications that I've already talked about, and our privacy considerations. And then clinical staff need to be comfortable asking appropriate history questions. So again, if it pertains, ask the question. If it doesn't pertain, you don't need to. And then, you know, create a welcoming space, just like you would for any other patient. So let me tell you on the next slide. Whoop,
sorry, there we go.
That's okay. You're doing a great job, Paul. I know it's hard to forward somebody else's slides. So here's what we've done at the college. So we changed our processes completely, but it was only a couple of steps that we changed to make sure that we are collecting this data on everyone that comes in. So when someone calls to make an appointment, our registration staff do ask for both patient's legal name and their preferred name, and they enter it into the EHR in the demographic field. So we get that right out of the way. Then when patients come in, they update annually our consent form. And on our consent form, this is actually a copy of it right here, you can see that we have asked for their name as listed with your insurance plan and their preferred name, nickname. And then underneath that, we've added gender identity pronoun questions. So, you know, pretty self-explanatory here. This paperwork then goes with the patient and our student back to the exam room where the student and the provider both review it. And we have a discussion if we see, gender non-binary, but again, we don't really have a conversation with the patient unless it's an issue, but we just want to make sure everybody's aware that that's what's going on. When we're done with the exam, assuming that everything was straightforward with the exam and it didn't necessitate any further conversation, this paperwork goes up front with our patients when they check out, and then our front desk staff go into the demographic field and add the gender information into the gender field. And like I've already mentioned, we have our gender field highlighted in yellow so that we don't forget to do that. And it's been working pretty well. Now, I will say, we put this in place right before COVID and everything kind of flew out the window, but we're getting back into this and we're doing it fairly consistently now, and it's working beautifully. So it was a very simple change. Everyone's on board, and this is what we're doing with every patient now. The other thing I wanted to point out too is that, be even careful using the term transgender, because not every transgender person is comfortable with that term. So this comes from, again, the US Transgender Survey. And you can see here that there's, again, a spectrum of how comfortable transgender people are with being labeled transgender. So, I would just say, avoid bringing up the topic unless it's appropriate to the exam, which I've kind of beat that horse dead. You probably got it now, but and this was a great quote: having to teach your healthcare provider how to care for you as a trans person gets old really fast. Most trans people just want to talk about their sore throat, eye exam, etc., not about being trans. I thought this was great. I found this recently. It's called the TRANSCARE Approach, and this is from UIHC Hospital out west. And you can read through this. I think, again, it reiterates the main points that we've talked about here. And again, you'll see, concentrate on care, not curiosity. For example, it's inappropriate to ask about genital status if it's unrelated to care. So I'm not going to read this to you point by point, but, it's a great little thing to just kind of print off and kind of embed in your memory, I think. All right, so in summary, how do we create a gender inclusive practice? Remember that eye exams might very well be a positive entry point into the healthcare system for patients that have encountered, barriers and have had previous bad experience. So let's do better. Let's do better as optometrists and eye care providers. Increase awareness and provide training for yourself and your staff and the other providers in your clinic. It's very important to standardize that documentation protocol. If you don't standardize it, then you won't get consistent information and everybody will be doing it different. So I think that standardization was really important. And to be honest with you, we had little to no pushback. We took it to our clinical people and they said, yeah, that sounds great. And we did it. I know it won't be that easy everywhere, but I don't think it will be as difficult as maybe some of you assume too. Use gender neutral pronouns to address people, and address people by their preferred name. Obviously use gender inclusive, neutral signs, decor language. An idea that I love is having name tags or having a pin that you might wear on your lab coat that indicates that you're an ally. They're very easy to get your hands on these days. And really, most importantly, don't be afraid to admit your ignorance. I think transgender people are aware of the fact that not all healthcare providers are super comfortable with this issue yet, but I would also tell you, I think that mentality and that tolerance probably has a shelf life. This is becoming a mainstream enough issue now that we all need to have at least a passing understanding of what the major issues are here for this population. So certainly if you stumble, apologize and move on. It's not the end of the world, but acknowledge it. Here are some great resources for patients. We have, a transgender specific suicide hotline. And then the Trevor Lifeline. Paula can speak to this a little bit more, but this is going to be more for our young patients. Great resources to have on hand.
Yeah, so for both of these are both numbers that I really wish that I would have had for that first patient that I talked about. The transgender suicide hotline, we've got numbers for both the US and for Canada, but there will be a transgender individual on the other side of that line. And I know for that first patient that I saw, she was kind of like, well, what's a therapist going to do that they haven't done already? And if I would have been able to have this number to give to her, I think I could have given her a little bit better resource. There is also the Trevor Project Lifeline, which is specifically for your youth patients. So those are great numbers to have on hand. Or if you go to translifeline.org or the trevorproject.org, they have all of those phone numbers available for you there. Next couple of pages are just resources, things that Lil and I found really helpful as we were researching this. So you can look through those on your own. We have a whole page of websites, and then we have so many references. This is just the very surface of it. We started this 2.5 years ago, and as we were looking through updating our resources and our references, there has been so much published, even within the last year or so. So the good news is we are getting more and more information all the time, but like Lil has said before, it can be a little tough to stay on top of everything that's new. So there's not a lot out there specific to eye care, but there are a lot of references out there if you want to dig into this topic a little bit deeper.
So much published in 2020. I swear, people just spent all of pandemic like cranking out articles, cranking out papers on transgender care, because there was a bunch that came out in 2020. So yeah. So all right.
We did have a couple questions in the chat, and one was specific to your hormone blockers. So I'm going to start out with that. And certainly, if you have more questions, feel free to put them in the chat. We're happy to take those from you as well. Lil, there was one question, again, regarding the hormone blockers, talking about boys starting at 12 to 14 years old. Are those patients who were born male?
Yes. So hormone blockers can be used both for male and female. So yes, but in that 12 to, essentially what we're trying to do is we would start those hormone blockers as young as the physician is comfortable doing so. And what we're trying to do is we're basically trying to get ahead of puberty. And that's why there's so much variation, right? I mean, if you have teenagers, or we've all been teenagers, heaven forbid, it's been a long time ago, but everybody gets to puberty at a different age, right? So they want to get those hormone blockers really started before puberty. And the reason for that is, and to make this connection, where the gender dysmorphia really starts to become evident, where it really starts to, impact daily life, is when those secondary sex characteristics start to develop. So it's one thing to feel internally that you are, female when you're a little boy who maybe doesn't have to deal with, female anatomy. But it's a very different thing when all of a sudden, you're starting to develop body parts that you don't want. And so we want to get ahead of that puberty and those secondary sex characteristics so that we can prevent some of that really significant mental health anguish that goes along with that. Sorry, that was a long answer for a short question.
Great. And we're getting a lot of good questions, both in the chat and in the Q&A. Another one, a question about what is pansexual on the first slide. So on that very first slide over on the sexual orientation, pansexual was one of the terms that was listed there. Somebody who is pansexual is sexually attracted to any person, regardless of their gender identity, whether that's male, female, somewhere on the spectrum, sexually attracted to any individual.
Great.
Another one that, Lil, I don't know if you came across this book in your research, but somebody wrote that there's a book about neuroscience and gender called Brainstorm, The Flaws in the Science of Sex Differences.
I didn't, but you better know I'm writing that down.
Yeah, that's why I was slow on that slide, because I was writing it down. Looks like a really fantastic resource. Looks like it interrogates the role of social conditions in creating behavioral differences between gender rather than anatomical.
Yes.
And there's a lot of, some of the resources that I look through try to kind of compare to, the animal world, or looking at animal studies on gender. And I think as humans, it's nice and easy for us to split things into two distinct categories. But I think the more that we have this research, and like Lil said, the more that we have the data, things are just not that nice and neat.
Yes. So Paula, are you looking at the chat or are you looking at Q&A?
Well, I've got both up.
Okay. Great, so, thanks. I'll let you just run that show if you're good with that.
Sure, yeah. I'm trying to keep up with them here. I'm going to stop sharing if that's okay, because then I can see the chat boxes a little bit better. All right, so the next one on there, what do you do when a transgender patient gets very agitated and possibly unruly because of your ignorance that they are transgender?
Wow. So I'm going to guess, just from the specificity, I mean, Paula, feel free to jump in here, but I'm guessing that this is probably a personal experience. I can't say that I've had that experience, but certainly we've all had patients that become agitated or angry about something in the exam room, and I would probably just handle it the same way. Personally, if it was something that, I felt that I had initiated by, using an inappropriate name or an inappropriate pronoun or whatever the case may be, I would just, authentically apologize, which I'm sure is what everybody would do. But, if they're becoming violent, or if it's becoming, something more significant than just an angry or an unhappy patient, then I would probably have to ask them to leave and, apologize and feel terrible about it for the next 2 weeks. So would you do anything different, Paula?
No, I wouldn't do anything differently. And I haven't experienced that specifically. I have had, not my own experience, but I've had some students come to me that said they had a transgender patient that they think they misgendered, or somebody that they were working with misgendered. And, I haven't found that people are really agitated or unruly for the most part. A lot of times, from my experience, it's more like a discomfort, like, ooh, wish you wouldn't have said that. And more of like a shutdown of trying to give you any more information because you ignored the fact that they are transgender. But I think it's certainly possible that if somebody does get agitated, like Lil said, I would handle it the same way any other unruly patient in the office.
And I would say that that's probably someone that's dealing with some of those more intense behavioral health issues, and you just hit a trigger point for them unintentionally. I've actually had the exact opposite. I've had several patients, and I mean, keep in mind, we're in a small community. We just happen to have a public university that our college is associated with. So, and we still are getting a significant number of transgender patients that have come in. And I've had exactly the opposite. I've had such gratitude from the last really like 2 or 3 patients that I've seen that are just so grateful that we are asking about gender information. And, it was literally as matter of fact as me saying, I just want to confirm, the gender information that you listed on your intake form, just make sure it's accurate before we put it in the computer. And she was like, yes. And thank you so much for asking. And then actually making sure it's getting in your computer system. I mean, two really recent patients just floored that we were asking and so appreciative.
Yeah. And I think in our community, especially, they might be a little bit surprised that we're asking.
Yes,
but I would agree. I mean, the second patient that I talked about, he is no longer a pediatric patient, but he's coming in to see me because he knows that I respect his pronouns, and he feels very comfortable coming to our clinic. So, like, to reiterate what Lil said, the eye exam is a pretty non-invasive exam. We don't have to ask a lot of super personal questions. So it is a really good entry point into the healthcare system, or back into the healthcare system.
Yeah. I did want to just address one here in the question and answer. And this was, if a patient in your chair has relayed suicidal thoughts to you during an examination, what actions should you as their optometrist do to address this? And boy, I tell you, I'll just start as a jumping off point that Paula's experience with this patient really made us realize that as an institution, we needed to have some training on this. So we brought in some trainers that gave us an updated talk, CE, professional development here at the school about how we should handle those situations. But Paula, do you want to talk about what you did and then what you learned? I think you did great. So
yeah, oh yeah, it was really tough. It was definitely a learning experience. It was, when she came in the second time, she actually interacted with my student a lot, because our students bring the patients back and they start the workup. And my student came back and told me that the patient had expressed thoughts of suicide. So we had the conversation, well, we have to talk to this patient. Are they planning on going through with this? Do they have the means to do so? And yes, she did have the means to do so. We ended up calling the community mental health care department here in Big Rapids, and unfortunately they had to come and get her from the clinic. So we didn't finish the eye exam. Again, I would handle that patient very differently. Now I would probably call the transgender suicide hotline for that particular transgender patient. But otherwise, I think I would still find out, if the patient is getting any kind of help, where they're at on that scale. And it sounds like you might be getting more through this series about mental health type issues. So, it's a really tough situation to be in, definitely.
It really is. And, we all, I'm sure at some point, have dealt with the limited amount of emergency and urgent interventions available, right? I mean, we're in a small town, but it really doesn't even matter, right? I mean, there's not enough psychiatrists available or, mental health and behavioral health professionals available to all the patients that need them. So I would imagine that it's going to be a scramble, whatever community you're in, but certainly, as healthcare providers, we have to address it in a transgender patient or not. It's one of those things that we have to deal with in the office. So fortunately, it doesn't come along very often. Yeah. Someone had asked, would pansexual and bisexual be equivalent terms, or does pansexual assume that gender expression is fluid? Here's my take on this, and then Paula, Paula's the she's the terminology expert, and I'm the legal expert-ish, sort of.
Sort of.
I think that pansexual is an older term. I think probably a newer, more contemporary term is gender fluid. So I would say that fluid is going to be probably what you would hear more people using now, or much more so than pansexual.
Yeah,
is that an appropriate take?
Pansexual and bisexual, I think, are specifically referring to sexual preference, but it can be very confusing as you go through the literature. There are terms out there, as I was reading some of the older articles, terms like transsexual, which were referring to transgender patients, even though it has sexual in the term, it can be very confusing. So I don't have a great answer for distinguishing those two specific terms. But again, the language is changing all the time.
Yeah.
One that I thought was interesting, Lil, I don't know if you came across in your research any association between hormone transition or hormonal therapy and CSCR, central serous.
I have not run across that at all. If you have seen a paper, I would love to know the reference if you would pop it, at least the journal maybe that it was written up in. But I have not seen that. I think no, I have not. That's the short answer. Yeah.
And then another question, are there lab norms for transgender patients? Again, I haven't seen any specific norms. I've just seen kind of some preliminary studies. In the study that I referenced in the lecture, I think they looked at about 25 to 30 patients. So it was a fairly small number of patients that they looked at. But again, we have to get that data. We have to know that patients are transgender before we can even think about designing studies to create lab norms that might be more consistent.
I think that lab norming also in that whole discussion just really reiterates the point too, that these patients should really be under the care of an expert in transgender care. And that is certainly one of their barriers. There's a great paper that Paula and I read that really talked about the discrepancies in training in different programs and in different parts of the country for, physicians. And, some physicians get, a lot of training in this area, and some physicians never even get it in lecture when they're still in their didactic courses. So, I think that's just one particular area where an expert should be evaluating and interpreting their labs, someone who cares for many transgender people. But as of now, I agree with Paula, no norms that I have seen. So going back to a question, I'm sorry if I missed this, but when documenting that they are transgender in the chart, what's the best way, especially in the age of EHR portals? Teens may be uncomfortable if their parents have access. Okay, so those are kind of two different things to me. This is what your age of consent is, and your where you start as in your organization or by state law or whatever the case may be, limiting parents' access to their minors' charts. So that's kind of a separate issue, and I know that differs by, I believe, state law. So I know I was locked out of my kids' charts when they turned 13. So, but when I go with them to the doctor's appointments, I ask them, do you want me to come in or not? So there's no hard and fast rule about age of consent or when those privacy issues start to kick in. Okay, so I can't really address that part of it, but documenting in the chart, you can have simply two separate fields. You can have your current field, which is going to be our traditional sex identifier. So it's going to be their sex assigned at birth, which should also align with whatever is on their insurance card, because when that encounter is filled out, it's going to pull from your demographic window in your EHR, whatever their documented sex indicator is and their legal name. Okay. But you can have a separate gender field that's different from the sex identifier. So sex identifier, sex assigned at birth, gender window. Every EHR has that field available. You just might not be able to see it. You need to talk to your EHR software provider if you're not sure how to activate that field in your system. But by certification rules, every EHR has to have a window available, some way to gather gender identity. So it's there, you just have to find it. And then you just have to ask the question, and asking the question is as simple as changing your intake paperwork and just gathering gender data in addition to legal name, preferred name, and sex assigned at birth, or just legal sex, or whatever you want to call it on your documentation. And we do have an example in the notes if you look back.
And I think addressing the teens being uncomfortable if their parents have access to the chart, I mean, that could be true for a lot of different things too. And sometimes kind of going back to that conversation with the patient, even if they don't want to be labeled as transgender, they just want to go about being a male, sometimes you do have to have that conversation and say, hey, this is what we have in our chart. We have to have this for legal purposes, whether it's a teenager or an adult. If this reimbursement information gets sent to, a different provider, or if you have a letter that you're copying parents on, sometimes it's good to have that conversation with the patient so they're aware that, yes, there is a separation between their name and their legal paperwork. And you might have to adjust, if you're sending a letter that needs to go to another provider or to whoever's reimbursing the insurance that might not know, if their job doesn't know that they're transgender, but you send them paperwork as a provider for some reason that outs them as transgender, you want to make sure that your patient is going to be aware of some of those communications that may happen.
And again, that can be a really small, just things that you don't think about. One of the things that we forgot to change is in our EHR. Sorry, I was reading questions, so I hope you didn't already talk about this. But, one of the things that we didn't think about is that in our EHR, it auto-populates the chief complaint, right? So, or not the chief complaint, but it creates like a paragraph based on what you've inputted for the chief complaint. And it pulled from the sex assigned at birth field. So it said, this 22-year-old white female complains of, or something like that. So we just have that taken out. We have and so we might have collected data that said their preferred gender, or, their gender is male, but their sex assigned at birth was still female. So we were getting this discrepancy in that documentation. So we just went into our EHR and we looked for all of those occurrences where that auto populates, and we just took it all out and just had it say 28-year-old patient complains of, and just took out any reference to sex or gender in those auto populations. And that worked really well. And our EHR, we don't do any of this, right? We've got an EHR guy. And our EHR guy said it wasn't that hard to make any of these modifications. So I think if you have someone that's skilled in your EHR, it should not be difficult to make these changes. Mm-hmm. I think this is an interesting question. Do you find that those who refer to themselves as they are not really sure about their gender status? No. I would say those that refer to themselves as they are either transgender or they just don't want to label themselves in a binary system. It's been very interesting because I'm paying attention to this whole issue as I'm raising 2 teenagers. And I have found that they and their friends are just naturally starting to call people they. I'm hearing much less he, she, and much more they. So I think the younger generation is just incorporating this into their language. And Jane, I feel your pain, because that they thing was really hard for me to get. I mean, ask Paula. It's like, before we would give this lecture the first few times, I'm like, I know I'm going to say this wrong. I'm going to say it because, I was raised with a mom who had very strict grammar rules, and it feels very foreign. But they is a completely appropriate, gender neutral term, completely accepted.
Yeah, and I tend to find, this is kind of rolling a couple different questions into one, but there was a question about, is it tough to, if you do misgender a patient in the exam room, or especially patients who identify as they. For me, I've been trying to practice this a little bit. Like if I'm writing a note about, writing an email about a group of people, I won't refer to them as you people, I'll say them or they, or if I'm, referring to an individual person, I'll say they or them. So the more you practice it, the more comfortable it gets. Yeah. We found this, again, kind of rolling a couple questions into one. Did we initially start educating our staff or faculty, or was it simultaneous? When we first educated our staff, we had a specific staff training for them, and they were like, oh, that's going to be really uncomfortable. And same thing, we said, yep, it's going to be really uncomfortable. It was uncomfortable for us. The more you do it, the more you practice, the easier it becomes, both using they, them, and also with just asking those gender type questions on the questionnaire.
And they will also become one of your biggest sources of information too, because recently, since the pandemic, I have like a before the pandemic and after the pandemic. So I know it's been since we've come back. We actually had our staff, they were questioning on how it should go out to the insurance, right? Remember this conversation? And I said, hey, it'd be really helpful if one of you guys just called the insurance and asked them, what if the gender does not match what's on the insurance card and all that kind of stuff? And so they said, yeah, I'm going to do that. So we kind of had like this front desk task force that started calling a bunch of insurance companies and found out that we were doing it exactly right. What has to go out on that claim is their sex assigned at birth and their legal name, but that does not mean that you cannot collect a preferred name and gender status and record that in your record as well. 2 almost separate issues. So yeah, but it was great how they were like, yeah, let's get on this and figure it out and make sure we're doing it right. And they took that all themselves. It was wonderful.
Yeah. And really, if you're thinking about your adult patients, when you're talking to your patient one-on-one in the room, you don't really have to deal with the pronouns a whole lot because you're just addressing your patient and addressing them by their name. It really becomes more of an issue if you are talking to family or loved ones or guardians where that pronoun comes into play a little bit more. If you're super uncomfortable with it, you can just replace the pronoun with the name, and then that becomes a little bit easier as well.
Yeah, great advice. Great advice. Someone did ask, should I have a family member in the exam room during the eye exam? I would say to you that I think that you should follow your normal office procedures. I don't think you have to do anything different in the situation of having a transgender patient than you would with any other patient. So just whatever, I can't answer that. Whatever you normally do in your practice is what I would do.
Although we did get some questions submitted before the seminar that said, you know, what do you do if you have a parent that is not accepting of their teen or their child being transgender? How do you address that? Kind of like, which side do you take? And Lil and I think both kind of agreed that, you know, we have to be an advocate for our patients. So we are, you know, respecting the patient, and you may have to have that conversation with the parent if they start to get upset with you about using the patient's name or pronouns that they identify with.
You know, peds is just, you know, peds and dealing with teenagers is just, it's just a touchy subject sometimes, no matter what. So, you know, I think every one of those situations is just going to have to be handled delicately and, you know, specific to that situation, I guess. Someone has said, have you found unintentionally misgendering patients to be an issue while practicing? I'm specifically referring to non-binary people because from my experience, it can be difficult to distinguish whether they are male or female. So again, I'm sure that I misgendered people before I started asking. I mean, I know that I did, or, you know, probably what I did in my previous life before I knew about this topic was I just didn't address the gender. I just used the name and just, you know, because really the gender of the patient doesn't come into play. It's really not that important to the eye exam most of the time. So I just didn't address it. And, you know, that's not wrong to do even now. But I would certainly make sure that I got the gender information in this situation so that I just don't have to worry about that anymore. I just get the information on intake, then I've got it, and I put it in the record. And if you guys, you know, if you haven't, I think you're going to, now that you're aware of this and you start going to your next doctor's appointments or taking your kids in, this is becoming fairly mainstream. I mean, it's fairly mainstream even here in Michigan that gender is just on the documents. It's not that big of a deal anymore. And, you know, everybody's collecting this, or a lot of people are.
Mm-hmm. There was one question in the chat about, do you foresee future lectures about transgender patient care, including a trans person, so they can speak upon their lived experiences?
We would love that.
Yes. So
yes.
Lil and I, we've given this lecture at Academy for the past couple of years, and we did not submit this year, even though it has been well received previously. We have kind of stepped back in the hopes that a trans individual or somebody from the LGBTQ community can kind of step in and fill that role, especially knowing that there is interest in this topic now among providers. We have talked with some individuals across campus. We have an LGBTQ support group with our Ferris State University. So we've been trying to work with them, again, pre-COVID, to do kind of a joint, more interprofessional seminar for our faculty and our students. But again, that's kind of on hold at this point. But yes, that would be fantastic if somebody could kind of step into that role. So it was a transgender person giving this lecture. But we have also had colleagues come and talk to us after the lectures who I think maybe aren't comfortable as being labeled as transgender, or, you know, giving a lecture to hundreds of people saying, I'm a transgender individual. They just want to live their life as that gender.
Yeah, I agree completely. So, but we are reassured by the fact that we have gotten very positive feedback from many individuals in the transgender community, both optometrists and non-optometrists, parents of transgender children, that reassure us that we're giving good and accurate information. But we would love it if we had, we had a transgender colleague say, this is exactly the lecture that I would love to give, and just doesn't feel comfortable at where he's at personally to be able to do that. So hopefully someday that will happen, just happen organically. Yep. An anonymous, I think I just jumped over a couple, but have you ever had issues with insurance claim if you put a different gender than how the insurance knows them? Yes, that claim will get rejected. So remember, gender is different from sex assigned at birth. Those are two different things. So, or legal sex or sex indicator or whatever you call it. So that the traditional male and female that's on the driver's license, on the insurance card, on their birth certificate, that has to match what is on the insurance card. And it is not illegal, and it is not insurance fraud, at least to, this is what we have been told by our insurers on how to do it. Legal sex assigned at birth goes into that demographic field in your EHR. Gender goes in a totally separate field. They don't have to match, but what does have to match is the legal name, and the sex as it is indicated on the insurance card has to go out on that claim. Okay, so, we'll call your insurers if you're unsure about that, but it can easily be structured in your EHR that way, so that that gender data does not pull into the insurance claim from your EHR. Only the sex indicator, sex assigned at birth does, male or female. Okay. I find that people over 70 usually like to be called by Mr., Mrs., and Ms. Okay, I agree with that completely. And when I have a patient of that generation, making generalities here, but it's usually pretty darn easy to tell what gender they identify with. And I certainly do still call them Mr., Mrs. Out of respect of, for their age. And I would say that that's probably consistent throughout the clinic. Would you agree, Paula?
I would agree with that. Yeah.
Yeah, we have a lot of elderly and a lot of, a lot of people of that age that come into our clinic. It's not very often that there's a question about how they identify. So.
Yeah, and usually you'll find that the individuals who are a little bit more traditional and really like that Mr. and Mrs., they'll look at that intake form and they'll make comments to you about it like, yes, of course I'm a man, of course I'm okay, yep, okay, thank you, Mr. whatever, let's move along.
But we haven't heard it as much as we were afraid we were going to. That was our front desk probably biggest concern, is that we were going to offend people by asking. And we told them, if that happens, please let us know. And I haven't heard of anybody being significantly offended or creating a fuss at the front desk by having that question on there. And again, I think it's happening everywhere, at least in Michigan. So I think they're just used to seeing it now. We're getting more comfortable with it. All right, so that is Q&A.
There was another question, Lil. Have you done any work on your curriculum in terms of making sure that optometric education is gender inclusive?
To make sure that we are educating our students about this issue, or making sure that optometry as a profession. So do you mean, are we making sure that we are gender inclusive in our students, that we are enrolling gender inclusive? You know what I'm saying? Are we?
Yeah, I know what you're saying.
Are we educating our students about this topic? I'm not sure.
I'm not sure. We are educating our students.
Yeah.
We will typically reserve this topic for their either third year or fourth year, but we have given this to the last several graduating classes. Lil talks about cultural competency in her public health course. We don't have, I think there are a lot of different places that you could put this topic in the curriculum.
Yeah.
Especially if you're updating your curriculum to include topics such as, behavioral health issues, race issues, just really disparities in healthcare. Public health would be a great spot. I think the doctor-patient relationship would be a great spot. But I agree. I think it is important to include that, because our students who are going to be caring for patients definitely will need this when they're in the real world.
Yeah, and our students have been really supportive about, learning about this. They think it's really interesting. So it certainly is including, and I think where our curriculum is just like every school right now, we're looking at all of these issues, diversity, equity, inclusion, and probably are going to revamp our curriculum completely around these issues. And then this would certainly fall, I would expect, into that curriculum track. So there's a lot of work in all the schools going on about this right now. All right, so in the chat, I work in New York City. I love this, that they have a flag which indicates which pronoun or nickname they prefer. So do you mean I'm curious, do you mean a flag that goes on the chart, like to indicate what gender, or I'm just curious what they mean by flag.
I know there are a lot of pins and, like Lil said, some stickers. We've talked to some student groups who have ordered stickers to go right on their name badges that indicate the pronoun. And I think those are great ideas too.
Yeah, great comment from one of our participants about, the idea of transgender patients being talked to about being, questions about being transgender when it's completely unrelated, and relating that to a very similar experience of being overweight, or having a family member who's overweight, and they got tired of hearing about being overweight every time they went to their doctor, no matter what their other issue was that they were there for. So that's a great comparison. And, we did go across campus, like Paula said, and talked to the director of our LGBTQ resource center. And she reiterated that point many, many, many times, that, transgender people don't want to always talk about being transgender, and they really are tired of educating their providers about it. So I would say ask relevant questions only. Have we gotten them all?
I think we've hit on most of the questions. Lil, did you want to talk a little bit? We had a question come in before, prior to the lecture about microaggressions.
Yes, I loved this question. So you all know that we took some early questions, and I think throughout the lecture we have had we've answered a lot of them, but I thought that this question about microaggressions was great, and it was literally just, can you talk to us about microaggressions that we might be inadvertently using with transgender patients? And so we hadn't looked that up. We hadn't learned anything about that. So GLAD, actually, the organization had a wonderful kind of photo document, and I'll just hit on some of the high points. So some of them we've already mentioned, but intentional use of an incorrect pronoun or dead naming, microaggression, probably the number one. Negative facial expressions, which I thought was a really good one and I probably would not have thought of. So when you hear a patient's transgender making some kind of, whatever, a negative facial expression, microaggression. You will never be a real man/woman. I don't necessarily even think that was micro. That's just aggression to me, but it's my interpretation. Or you are so beautiful for a trans girl, right? And Paul and I used to, one of the things that we used to say about, the social and cosmetic transition is do not comment on appearance. Even if you mean to be, complimentary, it's a microaggression. They're just attractive or not, and it doesn't matter. It's just, you wouldn't comment to anybody else on their appearance, most likely. So don't do it if it's a transgender individual. So when are you going to really transition? Meaning really as having the full surgery, right? Having top and bottom. Again, everybody's path is different and everyone will, do what is right for them.
Well, you may have mentioned this too, but their insurance coverage is so different person to person too, that, maybe an individual wants to have that surgery done, but they can't because it's too expensive or they don't have providers in their area. And you may have mentioned that a little bit already too.
I didn't so much, but yes, that's a huge part of it. When we talk about health insurance not covering particular procedures for transgender people, it is usually those surgical confirmation, gender confirmation surgeries or gender alignment surgeries. I can't even, again, that term keeps changing too, but those more, advanced surgical procedures are the specific things that are being excluded by many health insurance companies. So, and they're incredibly expensive, as you can imagine. They go on, but, you're my first trans friend. You need to shave if you're really trying to look like a girl. I would have never known that you used to be a girl or guy. Did you have the surgery? Are the hormones going to change your voice? They go on from there. I think, some of these, like I said, I wouldn't necessarily call micro. They just sound pretty aggressive to me, but I definitely, that intentional misuse of the incorrect pronoun or dead name. Someone did pop into the chat, and this is interesting. I had a patient whose sex assigned at birth was not the sex listed by the insurance. They had their gender legally changed. Yes. I guess another question to address this on the intake form would be needed. I think in that case, they would just probably enter what their legal sex is. I see what you're saying, because we have ours listed as sex assigned at birth. So that's a great point. I mean, that is so rare to actually be able to have your sex assigned at birth changed. I mean, that's incredibly rare. Yeah. So thanks for sharing that. Something also on the intake form, they asked about preferred pronouns and preferred name. Some patients get offended by this. Has this happened to you? Like I said, I'm sure it's happened, but maybe they didn't report it to the front desk. Also, I will tell you something that I still slip up and say, Paula, make sure I get this right. It's preferred name, but no longer preferred pronoun, right? It's just your pronoun.
Correct.
Because preferred indicates that it's a choice, and transgender feel that, this is not a choice. This is who they are. So it's not their preferred pronoun. It is their pronoun. So preferred name is still correct, but it should just be pronoun or gender.
Correct.
I do it. I still get that one wrong a lot too. I always have to ask Paula.
And, having preferred there makes it sound like, you can choose as somebody talking to me what you want to use. And that's not the case. You just need to use my pronouns.
Yes. There were a couple here. I was afraid that we maybe weren't going to have enough questions, and you guys really outdid yourself. Someone had asked, do we know the extent of underusage of vision healthcare services for this population? I'm going to say no. I have not seen that data anywhere. You're welcome, Sharon. I have not seen that data anywhere. I don't think that we have that granular of information yet. Hopefully, the next round of the transgender survey will help.
And I mean, that goes back to collecting the data too. I know when we talked to our LGBTQ representative across campus, she was saying that they really don't even collect that information for the college. And in some ways, they don't want that, the LGBTQ group doesn't want that information collected, because if they find that there aren't enough students who are reporting that they're LGBTQ, then they might lose the funding that they have. So it is important to collect that data, but there can be some really tricky political things that go around getting that information too.
Paula and I thought this one was interesting, and I think we kind of touched on it, so forgive me if I'm repeating. Recommendations. What recommendations do you have when a parent and guardian accompanying a minor is not accepting of the minor's identity? And then there was a closely related question of what pronoun is appropriate when the parent is inconsistent in identifying their child. So the first thing that I would like to address is that inconsistency. What I have heard from a number of people is that they feel terrible when they do this, but sometimes they unintentionally dead name someone because it's been their name for, 10 years, right? So, and I'm not saying it's right and I'm not making excuses, but it's, for me, a similar situation is when you have a friend who gets remarried, or the last name changes after you've known them with a particular name for 25 years. So I would try to figure out, first of all, is this inconsistency intentional because the parent's not supportive, or do they just slip up every now and then and call them by their old name? I could see that going either way. And Paul and I actually had discussion about this because this one's kind of tricky, and I don't see a lot of peds patients. But, it would really come down to how old is the patient, and, the patient is, the child is your patient. So, really you have to do what makes your patient comfortable. And so I would say take the cue there. Paula, do you want to elaborate on that at all?
I'm sorry, I was a little bit distracted by this next question, which is a really good one too. But no, I would agree with what you said. And I mean, kind of like we talked about before, if it is getting a little bit tense in the exam room, if the parent is comfortable with being separated from child, or child's going to be more comfortable just being on their own with you in the exam room, I think it's acceptable to ask, hey, is it okay if we separate you? We'll do the exam and we'll let you know about the exam findings.
Yeah. I think more often, though, it probably just wouldn't come up. I don't know. Anyway, unless they were taking medications, right? And then it would come out in history. So I think that would just be another one of those that you'd have to handle every situation differently.
So the next question, do you think eventually in healthcare that we should move away from the traditional case presentation script, for instance, a 30-year-old female? That's a really interesting question. I think, there's so much that is rolled into that. When you think about our typical case presentations, usually we are thinking about that case presentation based on sex demographics, based on age demographics. So I think, I don't really know how to answer that. I think it would be nice to have gender information in there rather than sex information. But at the same time, so much of what we learn right now about cases and conditions are based on age and sex demographics. So Lil, I don't know your thoughts on that. That's a really, really great question.
I do think it's really interesting. I personally, I don't think it will go away, but I think it will transition. I should use a different word, but I think it will morph into being gender inclusive. And I think, that is one of the ways that we as teachers and healthcare providers can kind of help start steering it in that direction, is just say, give me gender information as well, or, they are cisgender or they are transgender. And, I have a 30-year-old cisgender female. Why couldn't we say that? I have a 30-year-old transgender female. We could easily just incorporate that gender alignment in our presentation, and then that sets the stage, and then we move on.
Yeah. Yeah. Great question.
From Joy, there's a great article about this regarding race by some of our own SUNYs. Oh, thanks, Joy. I'll definitely.
Joy, if you have that paper or that link, we'd love
you
that.
You have our emails, Joy. Can you shoot us a link? I'd love to read that. Yeah, does anybody else feel like there's only so many hours in the day to read? I want to take like a 6-month just reading hiatus just to catch up on all of the stuff that's out there. There's so much good information and so little time to read right now. So, all right, couple more here. Oh, I think we got that one.
I think we've touched on most of these.
I think we have. And looking back through the questions that were sent in prior, I think that we covered them all, Paula.
I think so.
The last one, we said we were going to save this one for last, is how do we change the stigma based on sex, gender, and race? And what are the most effective communication ways to approach that? And Paul and I also had some discussion around that last night. I think it's a great question. And I really think that, this is where we start. We start by educating ourselves and each other. And, having some of these uncomfortable conversations in an effort to learn more, and just, feeling comfortable to admit your ignorance when you're just not sure, will go a long way. But I don't think anybody argues we still have a long way to go.
Yes. Yes. Yeah.
So that was a great question. I'm feeling pretty proud that we maybe ran dry the questions from a bunch of New Yorkers, Paula.
I'm glad. Thank you for organizing this so that we had a full hour for questions. We always have so many questions that we're trying to get through and trying to make sure that we hit on everything. So it was nice to have the extra question time.
Wonderful. Wonderful to have this time for questions. We really appreciate it. I think it really added a lot to the information too. So.
Well, I'd like to say this was an amazing course, and my phone has been going off the hook with comments and emails like, this is fantastic. Oh my God, thank you for doing this lecture. I'm trying to manage some of the back end conversation as far as positive feedback. So I want to thank you both for presenting this amazing lecture. And I think it's like we said earlier, this is a topic that is extremely relevant and should have been relevant, but it's very relevant. And the fact that we were able to do it on the last day of Pride Month, which is great. And like I told the audience earlier today, we will be providing the lecture, and this will be the recording of the lecture, and it will be the entire lecture, as well as the Q&A session. So you can have something to reference back, because I know that I got emails like, oh my God, I got cut off. So you're gonna have this, and it's gonna live on our website. Let me see what else I wanted, some other remarks. Thank you both for your time, your dedication to this cause, as well as this lecture. Keep it going. I think we're going to see a lot more of these lectures happening. Just as a reminder, as part of our series, we do have every last Wednesday of the month up until September in our Building the Inclusive Practice. I'm just going to read this and make sure I don't say nothing incorrect. On July 28th, we'll have, as part of our series, Expanding Understanding of Mental Illness, Neurodivergencies, and Disability. On August 25th, we'll have the Skills-Based Crisis Response for Optometrists, Faculty, and Students. And on September 29th, we'll be discussing Beyond the Exam, Practical Ways to Improve Patient access to care. Those registrations will be made available within the next day or so once this video is online and our website is up to date. We will also email it to everyone that was on today's webinar, as well as on our mailing list. If you have any questions or need anything, feel free to reach out to me at CE, so continuing education at sunyop.edu, and we'll be sure to answer your question as soon as possible. Without keeping anyone any longer, have a great night. Thank you again to our wonderful speakers, and have a good night. Take care.
Thanks so much for having us again, Betsy.
Anytime.
Wonderful.
Great. Oh, thank you.
Take care.
This is
Have a
great.
good night.
Look forward to having you again. Good night.
Thank you. Good night.